Hello, 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 and thank you for joining us for Ask Miss Jai Live. Today, we're going to be talking about how to conduct a sexual health assessment with transgender and non-binary clients, and some of the things you should keep in mind before, during, and after a sexual health assessment. So stick around and learn a little bit about how to conduct these assessments in affirming and inclusive ways. Welcome to Ask Miss Jai Live. My name is Miss Jai. I am so excited to be here today to talk to you about how to conduct a sexual health assessment with trans and non-binary clients and how to create an affirming, supportive environment to talk about a really sensitive topic with our gender diverse patients and clients. If you are catching this live, please go ahead and put a hashtag live in the chat. You can also write any questions in the chat as well, or any ideas that this is sparking for you in the chat. If you're catching this on a replay, go ahead and put a hashtag replay. Let me know the parts that are most interesting to you, or the questions or the ideas that this is bringing to mind for you on how you can provide support to trans and non-binary clients and patients during a sexual health assessment. So like I said, my name is Miss Jai. I use she, her, and he, him pronouns. I'm the host of Ask Miss Jai Live. My background is in supporting trans and non-binary people in public health settings, both in prevention and in care, and also providing services around HIV prevention and HIV care. So oftentimes a sexual health assessment was part of the conversation that I was having with clients, whether that be because they were coming in for testing, or they were coming in to enroll in PrEP or PEP or HIV care, or they were coming in to receive treatment for sexually transmitted infections. So a sexual health assessment was almost always part of my work over the last a little over a decade. So I want to share with you all some of the ways that I have learned to provide services to trans and non-binary clients and patients that is affirming and inclusive so that our health needs are still being met. We're still collecting the information that we need for the sexual health assessment, and folks are being treated with humanity and dignity and getting their service needs met. So the first thing that we want to do is we want to set the stage. And what I mean by set the stage is that we want to think about how we are supporting our trans and non-binary patients and clients before they're getting into the services, before we're getting into the conversation around sexual health. Folks might feel apprehension, anxiety, fear, distrust, mistrust around talking with a provider, especially around something sensitive like sexual health. And that can be heightened for trans and non binary people because of the ways that trans and non binary people have historically been treated in health settings, in public health settings, and around their sexual health and around their bodily autonomy. So some of the ways that we can set the stage is we can make sure that we're asking our clients, all of our patients, their sexual orientation, their gender identity, what pronouns they use, and what name they would like the clinic to call them by. This is a way that we can just provide equitable support to everyone that we're serving and make sure that we are calling people by the name that they use and using the pronouns that they use with them. It establishes rapport, it builds trust with our clients or our patients right away, and it shows folks that we are going to respect their identity and the identity that they are telling us in the health environment that we are serving them in. So we want to ask that information first. Another part of setting the stage is making sure that folks understand what they're going to be asked questions about and why we're asking that information. Trans and non-binary people who receive services often are asked invasive questions about their bodies, about the ways that they engage with other people, about the functionality of their bodies that are unrelated to the actual medical necessity for why they're being seen. This could be because of curiosity from the provider. This could be because providers haven't served a lot of trans and non-binary people, so they don't understand that it's inappropriate to ask these questions. Or it could be because we are being asked these questions and they are medically necessary, but we're not told why. So we put our own lens on it of like why this isn't actually necessary. So part of setting the stage is also explaining what questions we're going to be asking, explaining why we're asking those questions. So I'm going to be asking you about your sexual partners and sexual behaviors. This is so I can get a better understanding of the ways that you engage in sexually, so that if there are other types of tests, other prevention methods that I would recommend to folks, then I'm able to give you those recommendations and do that accurately with you. And so I can be respectful of, I don't want to make assumptions about the ways that you engage or the way that your body interacts with other people's bodies. So we want to explain why we're asking this information. And then at any throughout the entirety of the health assessment, but also before we start the health assessment, we also want to provide opportunities for our patients to exhibit and express bodily autonomy. So, if there are going to be portions of the health assessment that involve me touching a person's body, then making sure that I am asking before I touch the person's body or explaining before we even begin the assessment and say there are going to be portions of this assessment that will require me to touch your body. Maybe we're going to be doing a throat swab. Maybe we're going to be doing a rectal swab. Maybe we're doing a pelvic exam. Whatever that might look like, I want to be able to express that to the patient or the client ahead of time so that they can be aware that that is something that is happening. And then I want to ask permission to move forward. So, are you comfortable with answering these kinds of questions today? Are you comfortable with having this kind of assessment today? Do you, now that you have this information, are there any concerns that you have? Is there anything that you'd like me to let me know before we begin? These are all ways that we can put autonomy back into the hands of the patient to let them know that they can opt out. And also just letting them know at any point during this exam, at any point during these questions, if you don't want to answer these questions, if you want the exam to stop, you can just let me know and we will stop. So giving folks, again, that bodily autonomy. The next thing we want to do is we want to make sure that we're asking open-ended questions and asking open-ended questions about partners, sexual partners, as well as sexual behavior. So we don't want to assume someone's sexual activity based on solely on their sexual orientation or their gender identity, because when we make those assumptions, we have a tendency to be wrong around those assumptions. And when we're wrong, then we are potentially going to be missing assessing for health concerns that we might need to assess for, or opportunities for testing or opportunities for treatment. Um, or we end up making assumptions about the ways that someone's body actually looks. And when we make those assumptions, then we might miss out on entire screening questionnaires. So we might assume that someone doesn't have a cervix based on the way that they present. And so we miss out on screening for cervical cancer, or offering cervical screening services now or in the future. So we want to ask open-ended questions about sexual partners and sexual behavior when we're doing a sexual health assessment, because we don't want to rely just on the sexual orientation or gender identity of the person from the paperwork that we've received. So some of the ways that we can ask about that. So we might ask about sexual partners by saying things like, how many sexual partners have you had in the past X amount of time, in the last 6 months? We might ask, what is the gender of your sexual partners? If someone says that their sexual partners are male, then we might ask, have you had cisgender male partners and transgender male partners, just cisgender male partners, just transgender male partners, or any non-binary assigned male at birth partners? This helps us to get more information, because if someone says to us that they're only having sex with men, and we assume they only mean cisgender men, and they themselves are a cisgender man, then we might assume that there's not a necessity for things like birth control. But if they are having sex with cisgender men and transgender men, then there may be the potential for conception. There may be the potential for unplanned or unexpected pregnancy. And so we might need to have conversations around contraception. What kind of birth control is your partner on? Are they on any birth control? Have you taken steps to prevent unplanned or unexpected pregnancy? So those are conversations that we might have. And then when we're asking about sexual behavior, some of the questions we can ask are, what kinds of sex do you have? Have you had receptive or insertive sex? If you're having oral sex, are you giving or receiving? Asking about site-specific sexual activity too. So have you had anal sex? Have you had oral sex? Have you had vaginal sex? If vagina or vaginal is not language you use to describe your body, have you had front hole sex? Have you had any sort of receptive sex with a partner? Do you use any sort of toys? Do you share toys with partners? Because these are all ways that we might want to screen around the the potential for testing, right? So if someone is having receptive sex, then depending on the site, we might be able to do a urine sample to check for gonorrhea or chlamydia. We might need to do a swab sample. So if someone is having receptive anal sex, then we might want to do a swab for gonorrhea or chlamydia. If someone is sharing toys, we may make the assumption that there's no penetration taking place. But if someone's sharing toys or sharing prosthetics, with multiple partners, then there might be, or between partners, between themselves and their partner, then there might be a potential for things like bacterial vaginosis or other bacterial infections. So these are ways that we can assess to get a better understanding of the ways that folks are engaging, so that we can then provide accurate options. The other thing is the next thing is we want to use gender neutral and affirming language. And so when I say gender neutral and affirming language, I mean the ways that we talk about our bodies and talk about bodies anatomically are sometimes gendered. So, for example, I mentioned before that someone might not use the language vagina to refer uh, to their genital opening, to their frontal pelvic opening, right? So we can't assume what someone calls their parts. And for some folks, calling their parts based off of just the anatomy of the part can be dysphoric. So it can shut down communication. It can make it harder to have conversations around sexual behavior. So when we are getting ready, we might say, if there's language that you use to refer to your genitals, if there's language that you use to refer to parts of your body that you would like me to use, please let me know. Or what language do you use to refer to your genitals? What language do you use to refer to the types of sex that you have? These are ways that we can start to better understand the sexual behavior and the ways that our patients and clients talk about their body. But then we can also mirror that language, which is one of the tenets of public health, is making sure that we are using language that is culturally responsive to the patients and clients that we're working with. There's other language that we might think about as well that is gendered. So, for example, we might say bras or panties. We might, especially like panties, when we're thinking about doing things like a pelvic exam, we might say take off your panties. Things like take off your bra for a mammogram. So instead, we might say underwear. So moving towards less gendered language. We may also use language like male condom or female condom. Have you used a male condom? Have you used a female condom? So instead, we can say things like, have you used an external condom? Have you used an internal condom? This is how we move from gendered language to more gender neutral or least gendered language. In terms of affirming language, we can also make sure that we are using language that affirms the identity of the person sitting in front of us. So not all trans and non-binary people uh, lots of trans and non-binary people identify with a gender binary. So they may identify as masculine, they may identify as feminine. And so when we are talking to and about the person we're doing a health assessment with, we want to make sure that if they use a certain set of pronouns, that we are affirming that language in the ways that we're talking to folks. So if someone is masculine identified and uses pronouns he and him, then we want to make sure that we're referring to the person as he and him, that we're referring with masculine gender markers, that we're referring with all of these aspects around the gender the person identifies with. So this isn't to say that the most right thing that we can do for any of our trans patients is to default to a gender neutral space, but instead it's to have a conversation with our patients and clients and better understand the ways that they relate to their gender so we can provide them with the most affirming and culturally responsive care. The next thing is that we want to avoid outdated and violent language. So when I say outdated and violent language, I'll talk about the violent language first. So some language that we use when we're talking about sexual health, when we're talking about sexual health assessments, can be triggering for folks who've experienced trauma, especially sexual trauma. And working with trans and non-binary patients, we know that physical and sexual trauma are higher in trans and non-binary communities than in the general population. So we need to take a trauma-informed approach to the ways that we are supporting our trans and non-binary patients during a sexual health assessment. And so this means things like, instead of saying, to describe the sensation, for example, of a cervical a cervical screening or the collection of a sample, saying things like, you're going to feel a poke, you're going to feel a prick, I'm going to come into you now. Avoid language like that because it has a violent overtone and can be traumatizing and triggering to the person that you're working with. So instead, you want to say things like, I'm going to insert the speculum now. I'm going to use the speculum. You might feel a little bit of pressure now. So moving towards language that is less violent. In that as well, it's important to keep in mind that for trans masculine folks or non-binary assigned female at birth folks who have been on testosterone for an extended period of time, that there might be some shrinking of the frontal pelvic opening or the vagina, if that's the language that they use. And so we also might want to move from an adult size speculum to a pediatric size speculum as well to help prevent some of the discomfort or pain that might be experienced from inserting an adult size speculum. So other violent language we want to avoid. We want to avoid saying things like, "Go ahead and open your legs for me." "Go ahead and move your legs open for me." "I'm going to open your legs." We want to avoid that kind of language, and instead use language like, "Can you let your legs drop to either side? Can you relax your legs for me? Can you relax your posture for me?" Those are less violent ways to approach the conversation in doing an assessment. And then again, we want to avoid unnecessary touching of a patient. So I gave the example earlier, but depending on the touching as well, it can also be, and depending on the trauma experienced by the patient, it is a trauma-informed care approach to not unnecessarily touch a patient. So instead of guiding a patient down to the end of a table, saying, can you move to the end of the table for me? Or can you lay down at the end of the table for me? Or can you lay down and drape this sheet over yourself for me? So not touching the patient in those situations, and instead giving them, again, bodily autonomy to make those movements for themselves. And then in terms of outdated language, especially in risk category language, we might hear things like female to male, F to M, or male to female, M to F, or shorthands for those, right? So we might hear transgender M to F, transgender F to M. The challenge with that language is that when we are starting with the sex assigned at birth for the person, so female to male, meaning that someone was born and identified female and has transitioned to a male identity. Um, we're leading with language that is not affirming of the person's gender identity as they currently identify. So this can become confusing for folks who are unfamiliar with the trans community or the language that we use. And also it's a little bit bioessentialist. So we're saying, like, even though you identify as a man, we're still going to make sure that we are starting off with or kicking off with the fact that you used to be female. And so the shift nationally, the shift federally, the shift in sexual orientation and gender identity collection data, and especially around sexual risk data, is instead of saying FTM or female to male, saying things like trans man, transgender man, or assigned female at birth for folks who are non-binary. Similarly, instead of male to female or MTF, saying language like trans woman, transgender woman, or for folks who are non-binary AMAB, assigned male at birth. We also see another category called MSM, and this might be very familiar for for those of us who have worked in sexual health for a while, or for those of us who do HIV surveillance or are familiar with HIV prevention or care initiatives. MSM is a catch-all for men who have sex with men. There is a challenge with this category, which one of the challenges is that when we say MSM, we need to clearly delineate who we're talking about. So are we talking about cisgender men who have sex with other cisgender men? Are we lumping in transgender women to this category, which does happen occasionally and is a challenge because trans women are not men? Are we talking about transgender men who have sex with cisgender men? Are we talking about any men who have sex with any men? So are we talking about both trans men and cisgender men? And are those risks similar and are they dissimilar? So MSM itself can be a challenging category. And what we can do in revising this outdated language is we can be clear in who we are talking about and how we're categorizing this data. So if we're only talking about cisgender men who have sex with cisgender men, then we shouldn't be categorizing trans men or trans women to this category. And we should be separating that data out separately. The other thing we know is that trans men who have sex with cisgender men are at similar risk levels to cisgender men who have sex with cisgender men. And so there's been this misperception that trans men are not at risk for HIV, and not at increased risk for HIV. And we know that that's not true. And in fact, the HIV surveillance data shows us that from 2015 to 2018, there was a 40% increase in new HIV diagnoses for trans male communities. And part of that is because we are now collecting the data more accurately. But it's also important for us to recognize that this is a community that is also impacted disproportionately by HIV. So we want to make sure that we're being clear in that category. And then with any of our data collection, we want to update when it says other, especially around an identity. So a gender identity, other, sexual orientation, other, that we're just revising the word other. Because when we use other, we are othering a community. Instead, we can say not listed or provide a write-in option or say additional identity, please specify. It's just a nuance in language that is more affirming to the folks that we are working with. Finally, we want to offer testing, treatment, and resources that are appropriate for the behavior and the partners. So when we are doing sexual health assessments, we want to be talking about, this is why we talk about sexual behavior. This is why we ask about specific sites. So anal, vaginal, oral. This is why we talk about the gender of the partners that we are engaging with, because we want to offer testing, treatment, and resources that are going to be appropriate for the types of sexual behavior that we are engaging with in, and also that are going to help us to reduce sexual health risks with the partners that we are engaging with. So this looks like making sure that we're offering testing services that are site specific. If someone has an exposure in a certain part of their body, especially for a bacterial infection, we want to make sure that we're offering, for example, if someone has an oral exposure, we want to offer oral swabs. Because if we just offer a urine sample for testing for gonorrhea and chlamydia, then if there's an infection present in the throat, it will be missed and it won't show up on that urine sample. So we want to make sure that we're offering site-specific testing. We want to offer a status neutral approach to HIV prevention and care. And so if someone comes into our services and they receive HIV testing, then if they are HIV negative, we want to encourage them to get more information about PrEP and started on PrEP if it is applicable to their risk and the types of sex that they are engaging in. If so for both heterosexual people as well as people from the LGBT community. So we want to we want to kind of recognize the fact that like HIV is a human infection, and that PrEP can be applicable to folks who are at risk for HIV, regardless of their sexual orientation or gender identity. But the other part of the status neutral approach is that if someone comes in for testing and they're HIV positive, then we want to have services in place so we can link folks to care so that they can get started on antiretrovirals to get the infection under control. Because if HIV is undetectable, then that individual is not able to transmit HIV sexually to another person. So either way, we're working with folks to get into some sort of biomedical prevention opportunity, and get their health needs met. And then we want to offer resources that are appropriate. This is one of the reasons we ask about sexual orientation and gender identity. If we know folks identify as LGBT, then we can help guide them to resources that are designed and supportive and affirming to LGBT people. We know that if folks don't identify as LGBT, then resource opportunities open up. So we might be able to guide people to other kinds of resources. So we want to guide folks to the resources that are appropriate for their identity. We want to guide them to resources that are also appropriate for their sexual behaviors and their sexual partners. So if they say, I know that I don't use internal condoms enough, but I don't know where to go and get them, then we can guide them to resources in order to get internal condoms for free or for discount or have prophylactics covered or whatever that might look like. So thank you for taking the time to join me for these 5 steps. Again, setting the stage, asking open-ended questions about sexual partners and sexual behavior, using gender neutral and affirming language, avoiding outdated and violent language, and offering testing, treatment, and resources that are appropriate for the behavior the sexual behavior and the sexual partners are all ways that we can conduct sexual health assessments with trans and non-binary clients that are more affirming, that are more inclusive, and that are going to help meet the needs of our trans and non-binary clients and patients. And ultimately will support all of our clients and patients because we're going to get a better understanding of the ways that folks are actually engaging. And we're going to be able to have conversations that are more applicable to the individual as opposed to just general information about sexual health and risk reduction. So I'm grateful for this opportunity. If you are catching this live, go ahead and put in the comments what you found most interesting. Let me know which of these you feel like you're already doing really well, or if you have questions on how would I ask this, how would I talk about this, put those in the comments below. If you're catching this on the replay, same things. Let me know in the comments below. What do you feel like you're doing well already? What would you like some support around or language around? Do you have any questions on how you would ask these pieces or how you would navigate this within your environment? And if I know, I'll provide you that information. And if I don't, I will connect you to other resources. Again, my name is Miss Jai. I'm so happy to bring you Ask Miss Jai live every week. Um, we are going to be wrapping up this season at the end of March. So we're not going to have Ask Miss Jai lives during the month of April, and then we'll return for next season in May. So please add your questions here. Please like and subscribe to the YouTube channel at Ask Miss Jai so that you can get updates on when we launch our new season as well. And until then, thank you as always for investing in the health and well-being of trans and non-binary communities, and stay safe out there, my loves.